Hello, everybody, and thank you for signing up for today's presentation. I am Jen Arellano. I'm the Administrative Director for the Inland Empire Health Information Organization. Many of you that are on this presentation today are attending our coalition meetings, and some of you are not. But at this time for our coalition meetings, we are taking the presentations that we do at the coalition on the utilization of Manifest MedEx, and we're digging deeper into how to use Manifest MedEx in your practices. Today we have Dr. Barry Bittman, who is the Chief Population Health and Quality Officer for the Inland Empire Foundation for Medical Care, and he's going to demonstrate how to make Manifest MedEx work in your practices. So we encourage everybody to ask questions in the chat. We will be monitoring the chat. We also want to hear your feedback during the presentation, so we will provide a link to give for a survey in the chat, and we really want to hear your thoughts on the program today. So I will hand it over to Dr. Bittman.
Thank you, Jana. And I'd like to take this opportunity to thank Jana and Jamie for their hard work on this project. They did a lot of groundwork to make this possible. I thought before I actually got started, I'd give you a little bit of background on myself. I'm a physician, I'm trained as a neurologist, and I work as a Chief Population Health and Quality Officer for the Inland Empire Foundation for Medical Care. I am not a physician who's currently in practice, but I work with Dolores Green and her team at this organization to try to improve health outcomes and health practices throughout the Inland Empire. My background is I've been a solo practitioner. I've also been a Chief Innovations Officer and Administrator for a hospital system, and also the Chief Population Health Officer for Highmark Blue Cross Blue Shield in Pittsburgh. So I'm really thrilled to be with all of you today. This is a topic that's near and dear to my heart, and I welcome the opportunity to share insights and certainly answer the questions that you may have. So can we have the next slide, please? Okay, there we go. Okay, what we're really focused on today is looking at this challenge of taking care of at-risk patients from a new perspective. I want you to know that each of us is familiar with how challenging this can be. And as I've mentioned on the slide, it's awfully consuming as well. Bottom line is, failure of care coordination leads to poor outcomes. And you really can't do care coordination unless you really understand what's happening to your patients. However, there is a better way. And that's really to develop a comprehensive understanding of our patients' health and their history, and be able to anticipate a plan for their needs in order to improve their outcomes. You're probably saying to yourself, oh yeah, that's an ideal, but how can we ever accomplish it? Let me give you some real world experience to start with. Next, please. I want you to know this is an example that comes from my work in the Inland Empire. And undoubtedly, trying to move quality outcomes is extraordinarily difficult for times. But in recent years, we've developed a great deal of experience using Manifest MedEx, the HIE, to help improve the quality outcomes for two of our programs. One is the Foundation Accountable Care Network, which is our ACO, and the other is our Duals Direct program. And through these programs, I've had the opportunity to meet with many practices, many offices. In fact, I believe this probably encompasses more than 105 practices altogether, some large and some small. And what we did is back in 2016, when we started this initiative, we looked at 7-day visits. Now, these are the visits that are performed 7-day post-hospitalization. And you're probably saying, why are these so important? Because there's clear-cut scientific data, publication data, that shows that when you're able to see a patient within 7 days of discharge from a hospital setting, you can really improve their outcomes. You can improve their quality of life, you can fill in the gaps and you can basically reduce the potential for readmissions. So in 2016, only 55% of our ACO patients actually had a follow-up within 7 days of being in the hospital. In 2021, this is only 5 years later, now 84% of our patients in the ACO get followed within 7 days. Now, that number, that jump from 55 to 84 is pretty spectacular. And you're probably saying to yourself, this is an aberration. How could they possibly be doing so well? But the bottom line is that when we start to look at this really closely, we realize that using MX alerts and working with our practices on a daily basis and encouraging them to call patients and schedule those 7-day visits made a world of difference. Now, some of you are probably thinking, well, we're just basically looking at numbers here. And the bottom line is we're not, we're really looking at quality. So what I've done is I basically put together some information that basically shows that our present 7-day all-cause readmission rate, this is for patients who are seen within the 7 days, is only 14.5%. However, when you look at the fact that some of our patients, meaning 84% of them do receive the visit, but 16% don't, for that 16%, the readmission rate is an astounding 33%. So this alone should really demonstrate the value of having this type of information that represents not only a real-world experience, but it represents a real-time update for a practice that wants to improve its quality and help its patients. Can I have the next slide? As we start to move forward, you probably say to yourself, what does this mean on a national basis? Well, failure of care coordination, as you can see here, costs up to $78 billion with a B each year. And overtreatment or low-value care costs up to $101 billion. Now, I personally believe that if we're using an HIE, if we're using the full power of Manifest MedEx, and we're able to understand what's being done for our patients and where they're being seen and where they're being treated, we can eliminate this. But I also want to tell you, we have a $3+ trillion healthcare budget in this country. And there is no question that roughly a third of that budget is wasted. And what does that mean? It means we're doing stuff for patients that doesn't improve the quality of their life or reduce in any way, shape, or form the challenges that they're facing in healthcare. So my belief is the antidote to this is knowing what's happening with the patients that you're seeing. Next slide, please. There's a lot of confusion and ambiguity, especially with our chronic patients, and I want to share one of them with you. Maria lives alone. She's not doing well. Her symptoms are vague, and you have to realize this is coming from a neurologist. She's listless, she has fatigue and diminished appetite, which if you're looking to develop a differential diagnosis, probably includes 10,000 disorders. She's 74 years old, she calls her PCP and she gets an appointment in 3 weeks. A few days later, she feels worse. She goes to the ED, some basic blood work is performed, and there's a recommendation to see her PCP and a counselor because there's some suspicion of the fact that this may be psychological based upon the fact that there was a recent family tragedy. And that may in fact be possible. However, everything seems to go downhill from there. Her symptoms get worse. She progressively has more difficulty with her balance and listlessness, and that prompts a visit to the hospital. They do a routine workup, which is negative. She's discharged the next day on an antidepressant medication. Maria is a poor historian. She really can't provide a lot of information for her caregivers or her providers, which is pretty typical in this age group. And when she finally gets to see her PCP, it becomes apparent that the PCP didn't even know that Maria had been in the hospital. And while that's hard to believe, I want you to know that I speak with physicians all over the country that tell me we don't even know when our patients are hospitalized. Her PCP, however, agrees with the diagnosis of mild depression, basically prescribes a medication, and after taking the medication, Maria passes out, and she's basically seen back in the ED, a different ED this time, with a provisional diagnosis of drug effect. Seemed logical. She's subsequently sent home. She doesn't have a clue of what to do next. And the ED physician doesn't know her history. She basically presents without being able to provide anything meaningful. She's confused, she's downhearted, she feels like her life is falling apart, and she finally speaks to a friend who recommends seeing a neurologist, and her PCP subsequently agrees to a referral. 6 weeks later, the diagnosis of a stage 3 astrocytoma in the right parietal area is established. That's a brain tumor that's been growing during the course of this period. So when you look at this particular case, and there are so many Marias out there, you have to say to yourself, what could we be doing differently? How could we coordinate her care better? And what information do we really need? Next slide, please. As we start to look through this, it becomes very obvious that what's really missing is information in real time. Her doctor doesn't know what's happened. Her doctor doesn't have the results, nor even chooses to look them up because the patient doesn't relay that information to the physician. There is no global picture of the patient that we're focusing on. And a lot of the workups, the lab tests, all of the results go unreviewed. The bottom line is that if we were designing a treasure map and we had to get from point A to point B, if parts of the map are missing, there's no way that we would get there. In a similar manner, there's no way that we're going to be able to provide care for a patient like this when key information is missing. What we really need in 21st century medicine is the opportunity to understand and to be able to see that full picture of the patient. Now, if I would have given this presentation 5 or 10 years ago, I know what you'd be thinking. You'd say to yourself, well, that's pretty optimistic, but the bottom line is we really don't have the technology to be able to do that. And that's not the truth today, because we have some amazing technology that's right available at your fingertips. Let's have the next slide. The bottom line is pretty clear, and I love this slide. We really don't know our patients. I want you to know it's partially their fault. They refuse to get sick on schedule. They get sick whenever they feel like it. I'm only teasing. But the bottom line is we don't have real-time information to know where they're being treated, what's happening, and what they can do. Now, years ago, when I started talking about HIEs, and it has been many years, health information exchanges were just a conceptual framework for how we could share data. And I'd like to call that phase 1 development of HIEs. And the idea was, could we really move past the barriers of electronic health records? Could we translate information into a manner that all of us could easily see? Could we get a better picture of the patient? And there have been lots of challenges and roadblocks, but when we think about how fortunate we are in the area with Manifest MedEx, that's really behind us. But we're also in phase 2. Phase 1 isn't just knowing what's happening to the patient. It's getting the kind of information we need to be able to act upon that information, to be able to help predict the future, and to be able to better take care of all the Marias that are in our midst. Next slide, please. As we start to look at this, and you can see this individual on the slide pulling her hair out, I think that's how most practices feel. They feel overloaded, overburdened, and when you ask them if they would consider adding something else to a workflow, it's like, oh my God, I can't fit in another thing. But believe it or not, part of the problem is not based upon the fact that we're so overwhelmed with work, but it's we're basically spinning our wheels. We waste our time, and wasted time is never recovered. And I can tell you from having practiced for many, many years that just the time it takes to get medical records from other people, or to contact the hospital and ask for discharge summaries, or to try to figure out what's happened to our patients, especially our at-risk patients who are elderly and who have difficulty conveying a story, takes up so much time, and it's really wasted. Today, we're fortunate because that information is at our fingertips. All we have to do is basically sign in. Even without signing in, you can be alerted to which patients are being discharged from the hospital, the ED, other facilities, and you get that tracking immediately in front of your staff so that you can act upon it in a rather effective manner. Now, one of the things I want to talk about here is that time is extraordinarily important, because you're probably saying to yourself, well, I can get that information, I can respond, but saving patients' lives and improving quality outcomes is doing the right thing and the right place at the right time. And that's really where the HIE comes into play. Next slide, please. As we start to try to understand what kind of information is available to us, I want you to know that MX Access, which is where we can really see what's actually happening, has advanced phenomenally over the course of the last few years. When you look at the information we have over here, you can see that this is a particular patient. And I want to emphasize the fact that I've removed any PHI from this presentation, but this is a real individual who's been seen by multiple departments, has been seen in the emergency room, has been an inpatient in cardiology, and basically has had multiple encounters. The beauty is that when you start to look toward the right side of the screen, on one screen alone, you can actually see what's happened to that patient. You can actually get a sense of what's going on. You can quickly review a page like this in 30 seconds and get more information than you ever could. And it's simply at your fingertips. All you have to do is take a look. And if you look at the second one from the bottom, you'll see that we're not just talking about a cardiology problem, we're talking about a GI problem. And we're talking about a GI hemorrhage that's occurring in this patient. Now, very simply and practically, a patient that's been through multiple bouts of congestive heart failure, who's been hospitalized repeatedly, could potentially leave that out. So if you don't have that information and you're depending on the information that you're getting solely from the patient, my God, you're really at a loss. The way this is constructed is really to make life easier for us. It's to create an advantage that hadn't existed before. And you basically have data that comes from two different sources. One is clinical data, and the second is claims data. And if you look up at the right quarter of the screen, you will see all encounters, clinically sourced encounters, or claims sourced encounters. So you can pick. We have multiple sources of data that give us the information. And it couldn't be easier because on the left, you have a summary. You have all the patient's allergies. While you may not be interested in the insurance, certainly medications, problems and diagnoses, encounters, labs, radiology, procedures, you name it, are there. All we have to do is select. And one of the real phenomenal things about the HIE rather, is that it's catching on and more people are signing up. And we really have a tremendous amount of data in our system at this point. So let's go to the next slide. I really think that the focus of HIEs as we move into the future is not just, as I mentioned before, to give you the information, but to really help you with outcomes. Now, one of my areas of interest, just personally, is analytics. And I spend an awful lot of time with analytics. And usually the analytics are placed on one platform. So if you can imagine 10 hospitals in a region, 1,000 physicians, and each one of them is trying to develop an analytics process, it becomes extraordinarily difficult. Now you're probably saying, well, there might be that many physicians, but you probably only have 20 or 30 EMRs in the community. And that's probably correct for the most part, although there are a lot of smaller EMRs that I don't want to talk about. But the bottom line is Try to aggregate that data and doing analytics when you only have the information that's literally coming from your own EHR is so limited that it's absolutely meaningless. So unless you're doing this on claims, or unless you have the opportunity to do this with an HIE, there's no way that any type of platform that's placed on top of your EHR is going to give you this information. The only EHRs that really work in this are the ones that aggregate data from HIEs into them and give you the entire picture for analytics. So what's important here, and what I'm trying to emphasize throughout this presentation, is data can be extraordinarily limited. The information you get from your patient is limited. The information in your EHR only pertains to you or your clinic or your hospital or your center. The bottom line is the HIE goes well beyond this. It shows you exactly what's happening. So let's go to the next slide. I want to emphasize the fact that when we look at data aggregation and we look at putting multiple sources of data together, it's really not that easy. There's a lot of work that goes into this behind the scenes. A lot of work that goes through the system to make sure that this is clean data. We have a term called dirty data, meaning it doesn't really correspond. And there are a lot of checks and balances built into MX that make sure that what you're getting is the very best information that's available. From a population health standpoint, you're not just looking at that patient who's sitting in front of you during that scheduled appointment, but you have to be concerned with all of the patients that are on your roster, all of those patients who are attributed to you, all of the individuals that you're responsible for. And I can tell you right now categorically that the patients who are in the most trouble are not the patients that you see. The patients that get into the most difficulty are the patients that don't show up in your office. It's these people who go to urgent cares or other emergency rooms or seek other types of care from other physicians or providers that don't wind up on your radar until there's a major catastrophe. Now, I know you're probably saying to yourself, my God, this is probably impossible. How am I going to follow every single person in my practice? And that's where this new wave of technology is really helping us inside of HIEs. It helps us identify the 5% of the population that's moving or using more than 50% of the resources. And what I'm about to show you is some really phenomenal analytics tool sets that help you identify those patients. So next slide. This is a really cool screen. Now where it says PHI has been removed, these were lists of names. So every row represents a different patient. And I removed those names for the purposes of maintaining HIPAA security. But if you look at this list, this is an example of a roster in MX Analyze from a particular practice. You can see the ages of the patients, the genders. You can see which ones have the highest cost, which ones are hospitalized the most, which patients are seen in the ED, what their mortality percentages or potential, and what their COVID-19 mortality potential is as well. So when you see H or VH high or very high, this is danger Will Robinson. That patient is likely to get into trouble. And for you to do well and to best treat these patients, you have to become proactive with these individuals. So it's no longer, again, looking at today's roster and saying, I'm responsible for these 10 patients. All of these individuals are getting into trouble in the background. And you can also see some arrows on this chart, which I think are pretty interesting because they're really showing you the trending. Is this person stable, or are they getting better, or are they getting worse? So this is part of what's called MX Analyze, and it's really keying you into the information that you need. Let's have the next slide. Here's another one. And I basically love this screen because what this allows you to do is trend individual high-risk patients. So remember, we were looking at an aggregation, we were looking at a group before, but we basically take in the individual name of the patient out of here. We know that they've had 4 admissions, 6 ED visits, 60 outpatient visits, and their cost for the year, or their total medical expenditures, is roughly $73,000. Now, you're probably saying that's a major exception, but I can tell you I look at data every single day, and we have tons of patients in the Inland Empire that actually have expenditures in excess of $500,000 per year. When you look at future risk, these are predictions for this one particular patient. So you can see the estimated cost is going to probably be very high. Again, these are predictions. The COVID mortality is probably going to be very high. The bottom line is you have an identification of that patient over here in terms of all of the factors that come into play that make your job so much easier because you don't have to go to 14 different screens to look everything up. And even if you could look at those 14 different screens, it would probably take several minutes on each screen to figure it out. Here's one page that's showing you not only the relative risk for the individual, but it's also showing how the risk trend is evolving. And that's really the chart that you see in your lower right. This to me is a massive time saver. This to me is a way of making your practice so much more efficient. And this is a great way to anticipate the needs of the patients before they wind up in big trouble. I know I'm presenting a lot of information at this time. I hope that this is relevant, but I can tell you that as we move into the future, as you start to focus more on CalAIM, as you start to look at global payment systems that are coming down the pike, it's going to be more and more important to see that entire picture of the individual and to know who to focus on. Now, I can tell you right now, from an office perspective, you could see your 10 or 20 patients a day, and I'm not saying you're not doing good, but taking care of that patient with the routine blood pressure check or reviewing an A1C that's within normal limits is not the same thing as identifying a patient who's likely to get into major trouble and to use this information to help that patient have a better outcome. So that's a population health approach that can be adopted by all of your practices. Let's go to the next slide. Okay. Now, the real question over here is, what comes into all of these risk estimates? How do we really look at the data and figure out what the components are? And this is basically a breakdown for a patient. And you can see over here that every one of these factors, okay, has an odds ratio, and it essentially has impact on what that patient's future is likely to look like. So here we have a male between 75 and 84. You have 60 outpatient visits, 4 inpatient visits, 6 ED visits. And you can essentially see over here, and I think that this is really important as we start to work our way through it, that factors such as chronic diseases, medications, all of these different things make a huge difference here in the construct of trying to figure out what's likely to happen to the patient in the course of, let's say, the next 3 or 4 months. Even the zip code as a community social determinant has a high predictive value of what's likely to happen to that individual. So if you start to look at clusters of patients in different areas, there's some areas that people live in that are much riskier in terms of health and well-being than others. Let's go to the next slide. What you're looking at here is from psychosocial determinants. What do we really need to know? And perhaps our real focus should be on another project that Jana runs, which is Connect-IE. This is a program that was basically funded by IEHP. We're very appreciative of it. And it basically shows a phenomenal number of resources in the community that are essentially free or very low cost. Now, the bottom line for all of this is tremendous amount of work goes into it, and tremendous resources are available for those people in our community. Most practices are unaware of those resources. If you are, you can connect with Jana, and she can show you how to get connected with Connect-IE, pardon the pun. But the bottom line is that you can look at risk features, look at some determinants of community social issues. You can look at some patterns of utilization, and then you can say to yourself, what do we need to do and what do we need to cover and what more do we need to be able to understand about this particular patient to help them. So I hate to say it, but we sort of started backwards. We basically put all the community resources together. We have a phenomenal tool. It's absolutely an invaluable asset in taking care of patients who are challenged. But if you're not trying to figure out who these patients are within your system, it becomes extraordinarily difficult to be able to move forward. It becomes extraordinarily challenging as you're trying to realize what you're really trying to do in the context of taking better care of these patients. So here, if we just take a look at Analyze and we start to look at our rosters of patients, and then we start to drill down and look at their needs, then it becomes apparent that they need to be connected to Connect.ie. What a wonderful name. Next slide, please. Okay. This again is a slide that comes from MX Analyze. And what we're really focused on here is two issues, and both of these are really important. And while this is not perfect, it certainly establishes a risk class for 30-day readmissions or visits to the ED. And I hate to say it, but when you look around the country and you try to look at readmission rates, and these are all-cause CMS-based readmission rates, the typical numbers are 18 to 20%, meaning 1 patient in 5 who's discharged from the hospital is going to wind up back in the hospital within the month. And the number is even higher when you look at 30-day visits to the ED. When you look at this type of data and you can track an individual patient or a group of patients, you suddenly realize what's going on here. Now, let's assume that you're doing a 7-day visit. And let's assume that you're really conscientious and you want to take care of this patient in the best way possible. The logical thing to do is to look at the discharge summary, which is in Manifest MedEx. The next thing to do is really to get a wide perspective of what that patient's been doing. Have they been to the ED 6 times in the last year, as our last patient has? And the third thing to do is to go over to Analyze and say to yourself, what should we be thinking about? What should we be doing in better taking care of this patient? What are the steps that we need to take to be able to work through this process, to be able to truly provide the very best care imaginable? So when you start to think about all of those factors and you realize that this is not an hour of research, this is not going to tie up your staff, this is going to give you an opportunity in a minute or two to find out exactly what's happening, what's been done, to understand the discharge summary, and then to estimate the risk for readmission, it gives you an opportunity to be proactive. And the future of healthcare is about being proactive. Next slide, please. Okay. What I really like over here is that when you start to look at your cohort of individuals, and you're looking beyond those that are in your those that wind up in your waiting room. And you have to try to anticipate where you have to inject the best possible care. Screens like this really make a world of difference. You basically get to see risk classes, but you get to see it put together. So you will find that some people are more likely to come into the hospital. Others are more likely to be seen in the ED. Some of them have really high costs, but those who are associated with chemotherapy or other types of therapies, immune therapy is very expensive as well, or procedures that really consume tremendous amounts of expenditures for our patients. But you also get a sense of what the mortality risk is. And putting all of this together gives you a sense of being able to better treat the patient. For me, these types of screens are invaluable because now you're not just looking at the limited perspective. It's like wearing blinders when you're just looking at your EHR. And can you dig some of this out of your EHR? Yeah, but it's going to take lots and lots of time. So what we're talking about here is not just taking better care of people, but developing an efficient, effective workflow that allows you to address the needs of especially high-risk patients. Next slide. Okay, this is the breakdown of the factors that are considered in that inpatient 30-day readmission risk. And what MX is doing is taking a look at all of these factors, they're putting them together, and they're assigning a score. And for us to try to do this manually, patient by patient, would be absolutely nothing short of impossible. Next. So what are the final insights that we can share? One, healthcare is a changing landscape. It's really complex. In past years, we were responsible for the patients that showed up at our doorsteps. When I ran hospitals in the past, I did everything I possibly could to ensure the best possible care for our patients in the facility. But when they were discharged, they were off my radar. Today, that's not good enough because we realize that so many patients are falling through the cracks and so much money is wasted because we're providing services that are useless to these individuals. I'm not here to talk about economics, I'm talking about quality of life. If this was your mom or your dad or your grandmother that basically was being seen by a PCP, wouldn't you want that PCP to have every available information, every bit of information on what was happening with your loved one? Wouldn't you want to know the aggregate potential for your loved one to get into trouble? And wouldn't you want to know that the PCP, the internist, family practitioner, pediatrician, and so on, is doing everything possible to keep your loved one well? The bottom line is it's not going to happen in our chart alone. Now, I want you to know that EHRs are actually getting better because they're integrating data from MX into them. So this information is presented in the format that physicians typically review, which is the EHR itself. So bottom line, in order to move into 21st century medicine in a meaningful way, what we really have to do is see that whole picture. Taking care of those who are in your waiting room is no longer sufficient. And we're really thrilled to have advanced so far over the course of the years to be able to offer something that really is truly phenomenal. And I can tell you, you're not going to find a better person than Jana or Jamie to guide you through this. There are so many opportunities for physicians to get on board and to be able to connect with this type of information and to develop new and helpful workflows that can really engage your practice and your team on a level that you may never have considered before. This is true transformation, and this is the tool that can get you there. Next slide. Okay. What I'd like to do at this point is basically take your questions. I haven't had a chance while I'm presenting to look at any of them, so I'm going to ask Jana to review the chat and to throw any of those questions out at me. Thank you for listening.
At this point, we do not have any questions, but we welcome questions if anybody has. Thank you, Dr. Pai. And any questions for Dr. Bittman or on the workflows or on Manifest themselves. I will add, if you're not participating with Manifest, because a lot of individuals were invited to today's presentation, you could very well get signed up. You could reach out to me and Jamie, myself and Jamie. We are giving out $5,000 to $8,000 in incentives, or excuse me, $3,000 to $8,000 in incentives. And if you know providers or offices that would benefit for them for this incentive, please just send them our way. We do have only a couple of days left for the incentives.
And I want to be very clear in what I'm saying. I'm not employed by Manifest MedEx, but I work very closely with Jana on a number of projects. And if there's any way that I can help you move past barriers, help you with your staff or your practice, I'm going to make myself available. All you have to do is contact us. And Jana, I believe a few questions popped in. I saw them briefly on the screen.
Yeah, Justin has asked about how he could get access. He is a participant to MX Analyze. And Justin, I have your email. I'll follow up with you with Manifest so that we can get you a demo and get you all set up onto the Analyze platform.
And my recommendation is you just don't do it alone, but what you basically do is do the training with your staff, because there's a lot of lookup that they can do. And they can really tee you up for most effectively seeing that patient by just printing some screens for you. So this is a very effective way of developing a team-based strategy that can improve outcomes.
And I will offer Dr. Pai, he wants to know if anybody could check, can anyone check this data? As long as they're a participant, we do have to have contracts signed. So once we have the participating agreement, they will get access to the Access platform, the Notify, and the Analyze platform.
Any other questions?
Nothing came through. Thank you, Sarah, for coordinating with Justin on that for Manifest.
Okay, well, I'd like to take this opportunity to thank our team. I want you to know that the bottom line for me is that the future of healthcare rests in the information that we have to better treat our patients. And I am extraordinarily excited because I want to emphasize before I sign off, we're not talking about the future. We're talking about features that are built into this today, that all you have to do is turn on and go through a little bit of training. It's actually simple to use these tools. And then you begin that transformation. You become the transformation agent. With that, thank you for participating today and have a wonderful weekend.